Hello, I'm Andrew Brainerd. Welcome to the Essential Emergency Airway Care course. This is the first of 8 lectures. This one will be on airway preparation and team management. It's set up to how to manage an airway team in an emergency department, but most of the time, most of these lessons are applicable in many other practice settings as well. It's built around knowledge. So although there are many ways to run a team, it's most important to have a plan. And through our airway courses, we teach sort of this airway algorithm, which has been modified from the Difficult Airway Society algorithm. It's set up where we strongly encourage people to make and vocalize a plan A, plan B, plan C, and plan D, all with the emphasis on oxygenation. And this is set up where an example plan A would be laryngoscopy. If that doesn't work, they might try a different form of laryngoscopy, either direct or indirect. If that didn't work, they'd think about a laryngeal mask airway or a bag valve mask airway. And if that doesn't work, a cricothyrotomy. Sort of, again, it's plan A, plan B, plan C, plan D, with some examples. In this case, laryngoscopy, indirect laryngoscopy, laryngeal mask airway, and cricothyrotomy. Additionally, we have some tips, some sort of best practice suggestions, some suggestions on how to optimize your chance for success, reminders to bag patients and oxygenate them in between attempts, and some other hints on how to optimize for your success and how to contact help. This is a somewhat regional algorithm, and there's even talk of making it national. So no plan survives contact with the patient. So we'll talk about how to modify things. So the team leader is the one who sort of makes decisions and moves things forward, and usually in close cooperation with the primary airway operator. I know that in many places this is the same person, and it certainly can be, but it's also okay to divide these tasks up. A backup airway operator is nice, and it's something to think about. An airway assistant, someone who really knows how to run that back table, someone to provide manual inline stabilization if that's needed, someone to provide drugs and draw up the drugs, and then an extra person to cruise around and help out. Additionally, intensive care usually needs to be involved just in order to continue the continuity of care with them. So preparing the room, the most important part of the room, of course, is the personnel. It's nice to have some good resuscitation nurses, some ED consultants, some ED regs, and a charge nurse. ICU, of course, to continue things, and anesthetics, or somebody who's really sort of your institution's defined expert. To at least you'd like to know where they are. So preparing the room involves moving the bed to the correct position, having the airway cart in the correct position, and the recess tower correctly. There's quite a few knobs on that recess tower that need to be mastered. And additionally, the monitor has some technical aspects to it that are important. And then the airway cart. In most resuscitation rooms, the intubation drugs aren't located in the room, so it's usually worthwhile to identify them, to locate them, at least have a discussion about how and when you're going to use them. And then your backup stuff that isn't always in the room, your difficult airway cart or the video laryngoscope. So working the monitor is an important step. It's important to know that the pulse ox is the most important vital, should be put on first and not on the blood pressure cuff, and that the end tidal COT needs to be warmed up beforehand usually. The tower, knowing how the suction and the oxygen in the bag valve mask works, we'll talk about that in another talk. It's important. Usually the cart will go on the patient's right side, able to open the drawer. The top you'll set up, as we'll talk in another lecture. In our place, the bougies are on the side of the cart. Our basic airway adjuncts are the top drawer. Our intubation gears on the second and third drawer. Our laryngeal mask airways and supraglottic airways are on the fourth and fifth. And our surgical airways are on the bottom drawer. And this is common in many other hospitals, this general organization. So after the gantry and the bed and everything is in the correct position, it's important to make sure the gantry is worked. We'll talk about that later. The monitor is set up correctly, and the cart is set up correctly. Additionally, you'll probably need an IV, medications drawn up, and then your ventilator and your backup difficult airway cart or videoscope. You should know where those things are. So the key players are between the team leader, who's leading the resuscitation, and the primary airway operator, who's sort of making sure that oxygen is going in with the bag valve mask or the endotracheal tube. They need to have a pretty good conversation. And the rest of the team, super important as well. It's nice to have a backup operator with sort of some plans on when that backup's going to occur, who's going to perform the cricothyrotomy. It's important to talk to the airway assistant, make sure you guys are using a similar vocabulary. Oftentimes they'll help place the nasal oxygen, and have a little discussion as to what type of external laryngeal manipulation you'll use. Occasionally there's a few hiccups with the bougie tube combination, and that's nice to sort out as early as possible. Discussion about the meds, how the monitor is going to work, and involve intensive care as soon as conceivable. The indications, so this is like the classic test question. Of course, you need to make sure you're not just providing futile treatment. So in New Zealand, we're very good about sort of estimating the correct continuity of care for these patients. If you do intubate or provide advanced airway care for someone who is unlikely to benefit from it, you should be prepared to extubate them. An unprotected airway is the classic test answer. They're obtunded, they have a GCS less than 8, intubate, right? And cardiac arrest or severe trauma. Then difficulty with oxygenation or ventilation. They're basically inappropriate for continued bag valve mask or CPAP or bilevel. And then the clinical course, this gets a little, touchy, but a patient who's so agitated they're likely to hurt themselves or others. The airway's just going to get worse. You have an expanding hematoma, increased swelling with burns, a mass from an infection or swelling from angioedema. Those are all reasonable. And then need for pain control, need to move them to theater or CAT scan or something. And then expected end organ failure or severe sepsis or something to consider. There are different urgencies. So occasionally you do get a crash airway where there's a forced act situation. You have to work under extreme time pressure. Basically, you can't oxygenate, you can't ventilate from the minute they arrive. That happens. It's quite rare, and they're very difficult. But by far the majority of our airways are emergent, in which, although there's substantial time pressure, they can usually be oxygenated through other means. Usually definitely require some pre-planning, figuring out how their clinical course is going to go, and prepared under reasonably controlled circumstances. And then finally, there's the semi-elective ones, which are basically theater intubations that happen down in the ED when you just need to move the patient to CAT scan, or they have a toxic ingestion that isn't going to get better. That stand for a full assessment and lots of pre-planning. The airway assessment. So we're using these 4 acronyms, and even though I hate acronyms, it's important to sort of have some sort of standards that we can use across our institution. And these are taken from Juan Wall's emergency airway course, and none of them have a particularly good positive or negative predictive value for predicting the difficult airway. And certainly none of them are probably better than Gestalt for a experienced provider. But we have to learn our clinical Gestalt some way, so we'll go over these. So MOANS is an acronym for likely predicted difficult bag valve masking. So M stands for mask seal, difficulty with a mask seal. O stands for obstruction or obesity. A stands for age greater than 55. N stands for no teeth. And S stands for stiff lungs or C-spine. Lemon is probably more familiar with most people. The L stands for look for obvious difficulties with intubation externally. E stands for the evaluate, the 3-2-2 rule, which stands for 3 of the patient's own fingers should fit in their mouth, 3 of their own fingers should fit under their jaw, and 3 of their own fingers should fit between their hyoid and thyroid. It's basically can they open their mouth, do they have a reasonable jaw, and do they have a reasonable neck? It's a guide. M stands for Mallampati, is probably least useful in the emergency department. O stands for obstruction or obesity. N stands for neck, which means neck immobility. RODS is unfamiliar to me. It's how to predict difficult supraglottic airways. So restricted mouth opening and obstruction and disrupted or distorted airway. S stands for stiff lungs or stiff C-spine. And short is for a difficult surgical airway. S stands for previous surgery. H stands for hematoma, like expanding swelling. O stands for obesity. R for previous radiation in the neck. And T stands for neck tumor. These are just something to remind yourself of. They're actually on the back of our airway checklist to remind them, just mostly because I hate mnemonics so much. But it creates a common vocabulary that you can decide, is this going to be a likely difficult airway or a very difficult airway? So again, our team leader and our primary airway operator, our airway assistant, and our drugs, they need quite a bit of communication. And much of this communication can happen before the patient arrives. So it's probably important for the team leader and the primary airway operator to have a good conversation and sort of remind each other of the importance of a formal airway assessment, the vocalization and planning of a plan A, plan B, plan C, when you move from plan A to plan B type thing, the pull-out criteria, who's going to back them up and what the criteria are going to be, and what sort of the indications when you're going to crike the patient. Oftentimes mentioning a surgical airway early in the course seems to straighten up the team a little bit. And then the airway assistant, oftentimes there's some vocabulary problems with this person. We work with very different teams, and so a discussion as to what external laryngeal manipulation means for everyone, how to railroad that bougie tube combination sometimes causes trouble, and making sure there's a common vocabulary with the equipment names and sizes. And then drugs, early as possible, describing how you're going to get access, which drugs you're likely to use, and their likely doses can prevent some confusion later on in the resuscitation. And again, earliest as possible you can do this. I realize people are busy, but sometimes this can really alleviate some confusion later on. So here's an example. This is one way to sort of do a pre-briefing or pre-arrival briefing. And you wait till everyone arrives, take a short moment to introduce yourself. Hello, I'm Dr. Andrew Brainerd. Thanks for coming. We have a 40-year-old female here. She's taken a large poly overdose. She has a decreased level of responsiveness. She's vomited a couple times pre-hospital and is ventilating poorly. The paramedics and I are kind of worried about her. If airway management is indicated, I think we'll do a formal airway assessment. If it seems like it's appropriate to proceed, sounds like we should intubate her. So our team, I'll be the team leader. And Fred, you okay as primary airway operator? Linda, you can back him up, okay? And Viola, you want to run that back table as the airway assistant? And I'll push the drugs. Assuming there's no counterindications, let's just use RSI with thioin sucks. And our plan will be nice and simple. A will be direct laryngoscopy with a bougie and a 7.5 tube. B, video laryngoscopy with a 7.5 tube and a stylet. C will be an AirQ size number 3.5. And D will crike the patient, of course, if their sats are below 70. We'll use all of our best practice techniques that we learned from our course last week. And does everyone understand? So, Fred, you're okay with the plan, with our bougie tube direct plan? Good. And we'll do bougie, then video, then supraglottic airway, then crike. Yep. Okay. And you know where the crike kit is. That's very good. And Linda, you're ready to back them up. Very good. And our airway assistant, you know how we are going to do our external laryngeal manipulation. Yep. You know how to railroad the bougie in. I've seen you do it before. And just make sure you guys discuss all the equipment back there. You know the common names, and people are okay with the thioin sucks. Very good. Any questions? Yeah, Viola, if it's okay with you, Fred, I don't think we'll use cricoid. Okay, good. And great. Let's just make everything nice and slick for him to show up. If we have to intubate him, I want it to be us nice and ready. Okay? Very good. Thank you. So that's one way to do it. Who knows if it's that slick? Who knows if it's the best way? But it's certainly a way. To help us out with that, we've created an airway checklist and a preparation guide where this is on one side. Sort of the team can learn from it before their shift or during quiet part of their shift or before the patient arrives. It has sort of everyone's plans with quite a bit of detail on what different people do during an airway role. It has some prompts here on how to discuss some common sources of misunderstanding. To me, because I can never remember the mnemonics, it reminds me. And then a quick little example of a common sort of briefing. After all that's done, after everyone thinks they're ready to intubate and the drugs are ready to be given, any member of the team, you usually assign it pretty early, will run through this checklist in a call and response manner. We'll go over this later in the talk, but this is not a manual on how to intubate anyone. It's just a reminder. It's a checklist, and it's done right at the last moment before the drugs are getting given after everyone's prepared. Finally, tips to manage the team, right? Their entire course is on this. I do believe the more knowledgeable you are, the easier you're going to have, but that's not enough, of course. The more experience you have running teams, the better. The more you respect the team and they respect you. The more seniority you have, unfortunately, is true. Mannerisms can be both positive or negative. There is sometimes an age bias in certain teams, and I'm ashamed to say there's sometimes a gender bias in certain teams. Those things you generally can't help, But you can modify yourself to introduce yourself, make sure to ask everyone's name, try to assign roles as early as possible, have a good pre-plan, have a good plan, practice running teams and practice with the same team ideally, and then your volume, make sure you're not too loud or too quiet. So there's lots of evidence. Everyone should read an Airway book, an emergency medicine Airway book as part of their training. Life in the Fast Lane has a fantastic Own the Airway section. Ruben Slayer has a great talk on contemporary airway management. Of course, at Smack Gold, there's a great talk on checklists in airways. The Difficult Airway Society guidelines are something to review. You can compare them also to another type called the Vortex, which is a different way, and then another reminder on our things, on our mnemonics. Next, we'll go to oxygenating the patient, which is just as important, and I hope this wasn't too boring for you guys.